Welcome to this afternoon session. It's a great pleasure for me and Perla to present, last but not least, hopefully, our considerations regarding ethical guidance for patient-centered and culture-sensitive communication about dementia prediction, which is a kind of preliminary outcome also of our joint collaboration. And in the following talk, so the agenda today of our talk is, on the one hand, to develop ethical guidance for clinical practice and to inform policymakers about the do's and don'ts. Plus, I like to stress again that these are preliminary considerations. They are not fixed, so we are very grateful for your feedback. The background of developing such ethical recommendations is that there is a need to address the ethical challenges. We heard a lot in the last sessions about the ethical challenges about the use of biomarkers in the absence of any effective therapy. These dilemmas occur when we have to balance beneficence and autonomy, such as the right to know and prospective later life planning, versus maleficence, which is avoiding stigma, discrimination, or disempowering of people by their social environment. We also are convinced there is a need for being prepared, that the use of biomarkers will sooner or later be part of our clinical routine, and therefore we need definitely development of counseling services and related standards. And we also observed in our studies that lay people have a difficulty to distinguish between research versus clinical practice. So therefore we developed recommendations that address 4 levels of interactions that characterize modern healthcare systems. This is first the doctor-patient and the family communication, second interprofessional cooperation, thirdly public health promotion and media, and fourthly research, which I will explain in the next few minutes. So regarding doctor-patient communication, it's very important, as we already learned. This is complex and it requires very sensitive languages. It should avoid usage of negative stereotypes or to evoke any fear about dementia and stigma. Risk communication, as psychologists have shown for other areas, will benefit very much from using graphic tools, so this should be also developed. Firstly, it's important that Alzheimer's and dementia disease should be conceptualized and communicated as a disease in a process, which means, on the other hand, there is no black and white picture. This again allows addressing possibilities and capacities that are still remaining in this trajectory. Involving family is very important, but it's important again to stress that also family caregivers and relatives have sometimes own interests that need to be addressed. Therefore, patients should always authorize doctors to share information with such relatives and caregivers. And here we like to stress again that there is an advantage of predictive stage. Our very early diagnosis, patients are still competent. We suggest that there should be a multi-step approach to professional counseling, like a basic standard procedure that includes providing basic information via a flyer, or we can consider also internet websites before any specialized appointment takes place. Then we need a pre-test and the post-test counseling stage. So the pre-test counseling should include explaining risk and uncertainties, opportunities for risk reduction, a realistic presentation of existing therapies, and informing about the right not to share, as well as raising reflection why sharing information with whom might be helpful. There should be also information about the right not to be informed about test results even after testing. Post-test counseling should ensure that the information of stage 2 is still present, and it should provide a list of addresses or services for socio-psychological services and address in-depth issues of data protection. The counseling process should be systematically evaluated and improved for comprehensibility. This should also make clear that direct-to-consumer testing without professional counseling conflicts with these conditions and cannot therefore be recommended. The second point is interprofessional cooperation, which seems to us very important. Specialized memory clinics provide the best expertise. However, depending on where they are located, the access might sometimes be very difficult for people, especially in rural areas. So we recommend that exploring telemedicine care to overcome access hurdles. Depending on the healthcare system, general practitioners often serve as an entry point. So we consider that they particularly need specialized training and tools that support them during these information procedures to make these conversations informative and still in accordance with the complexity that is needed. And therefore, it's also important, as this is a fast developing field, we need platforms that help to update knowledge and sharing expertise. Another important point for us is that any of these networks should include social workers and psychologists, especially because they are very helpful entry points for populations with minority ethnic background. They should be included in networks and information procedures to reach out in these populations. Public health promotion and media play a very crucial role in health-seeking activities of laypersons. Neither they should use stigmatizing language nor reporting misleading salvations. And I think especially public health promotion campaigns from public institutions have a particular role in explaining the specificities of uncertainty and risk information to increase general health and numeracy literacy in the public. They should also provide more evidence-based information instead of overstating single study results. Developing specialized training for journalists seems to us meaningful to present the scientific complexity from prognostics, diagnostics, and risk reduction. And finally, we like to stress blaming strategies or fear-based campaigns should be avoided. They are both unethical means because they disempower citizens in their health-related behavior. Research is the last but also very important level of interaction, and here it became clear to us that it's very important that future studies should explore systematically impacts in short and long-term perspectives. This should include quality of life studies, psychosocial impacts, and planning behavior. Also, they should examine the various levels of stigma, including discrimination at working places. Special attention should be given to underrepresented minority ethnic groups, which are yet in most studies are not very well represented. And there are particularly important ethical legal issues that need to be clarified as soon as possible, particularly the usage of predictive risk information for public and private health insurances, as well as other insurances. Because in most countries this is only clarified for genetic testing but not for non-genetic risk information. Research should particularly include the target groups of this field, which are health lay persons with higher risk level, family members with and without family history, and persons diagnosed with MCI, SCI. To sum up, what we like to stress, there is the need for ethical guidance for very practice-oriented approaches. We also propose, of course, that our suggestions for standardization should include procedural adaptation. What could that mean? Something like including participatory approaches to address national and group specificities. And we also would like to suggest it would be good to have a broad exchange across different scholars in the ethical, legal, and social field to identify consensus areas for having a strong basis to develop also international guidance. So finally, I'd like to thank you for your attention, and Perla and I would like also to thank our both colleagues, namely Zümrüt and Natalie, for the wonderful collaboration in this project. And now I'm looking forward to your feedback and comments.